Medication reconciliation. One of the Joint Commission's requirements for accreditation is that we must provide medication reconciliation at all points of care and whenever medications are updated or changed. What exactly does this mean? Well, in the psychiatric setting, it means very carefully reviewing with the patient or patient's family every single medication the patient is taking, including any over-the-counters. When I'm doing this during a home care visit, I have the luxury of asking them to bring me the actual bottles themselves so that I can get the most accurate picture possible. One time I discovered that my patient had one bottle of the medication in its brand name form and one in its generic form, and she thought she was supposed to be taking one of each. Another time I was called into a home because the patient had had multiple falls in a 2-week period, so I had the family bring me the entire crate of medication bottles, and during this medication reconciliation process, I discovered that my elderly patient was taking Ambien and Ativan together at night. You never know what you're going to find when you dig into this. And even after you think you've compiled a comprehensive list, you should stop and double check that it's complete. I can't tell you the number of times I would reach that point in the admission process and I'd ask, so that's all of them then? No other medications like for blood pressure or diabetes? And before I could finish, a family member would cry, "Oh, you want them too?" And I'd end up adding 4 or 5 more medications to the list. Once that list is compiled, the next step is to determine whether the patient is actually taking the medication, and if so, whether they're taking them as prescribed. This is crucial because, as we all know, just because the label says 1 tablet daily doesn't mean that's what they're taking. After charting all this information, the next step happens after the admitting provider has written out or given you the patient's admitting medication orders. If there's a discrepancy between what the patient has been taking at home prior to admission and what the doctor now wants the patient to take, it's important to stop and clarify with the prescriber that this is a change in the patient's medication regime. For instance, let's say that your new patient, Marcus, has been taking haloperidol 10 milligrams daily at home. But when you get the admitting orders from the psychiatrist, you see that she's ordered haloperidol 4 milligrams daily. It's best practice and professionally appropriate to double check. "Hey, Dr. Crane, I just want to clarify that this is a change in the patient's medication, that instead of 10 milligrams of haloperidol daily, you want him to be taking only 4 milligrams daily." The prescriber has the chance then to say, "Oh, wait, actually, that should be 14 milligrams," or, "Yes, you've got that right." This can then be documented in a brief note, confirmed increase or confirmed decrease of haloperidol dosage with admitting psychiatrist. Then everything is clear and everything is covered. Remember, the Joint Commission expects this kind of medication reconciliation process to occur not just at admission, but also whenever medications are changed during the hospitalization. Final step closes the loop in this medication reconciliation process when, prior to discharge, we review with the patient exactly what his medication regime at home should be. This, of course, should start a few days before discharge if it's possible. And then, just prior to discharge, maybe the day before, since the day of discharge is often a busy, distracting day for the patient, review the meds again, this time having the patient teach back to you what exactly he or she is going to take and at what time of day. Of course, documenting that the patient was able to teach back to you his or her correct medication schedule is crucial. I'm not going to lie, this can end up being an awful lot of work. There have been times when I've spent a half an hour doing nothing more than clarifying and recording their medication list. But there's nothing quite as satisfying as doing this process carefully and discovering a medication mix-up that is at the root of the patient's problem. I had patients who were, in essence, taking in a chemical soup because of misunderstandings between the patient and family, patient and provider, or just years of accumulated meds that the patient thought he or she was still supposed to take. Look for at least one question on your exam regarding medication reconciliation.